Hello again. My name is Barbara Muffaletto. I am a program manager at Care Americas Global. I am joined here today with my colleague Karen Nicewender. We are the new co-chairs of the Care Group Interest Group, and we are very excited about this webinar. It is our first venture as co-chairs, and very excited to see all of the interest in this webinar as well. So thank you guys for your time today and for your interest in supporting and learning more about care groups. I am joined here today by our three colleagues, Riley Auer, Pamela Ncube Murakwani, and Chidziwisano. I'd like to go ahead and introduce them now, if Riley, you don't mind moving to our introduction slide. Thank you. So Dr. Kondwani is a lecturer and research fellow in the Department of Public and Environmental Health and WASHTED Center at the Malawi University of Business and Applied Sciences. He is an environmental health and behavioral scientist with a specific focus in low and middle income countries. Dr. Kondwani employs mixed methods approaches to understanding how compromised WASH impacts food hygiene, mental health, child health, and behaviors. Kondwani received his PhD from the University of Strathclyde, Scotland. Welcome, Mr. Kondwani. Riley is a social behavior change project officer with the USAID Advancing Nutrition, where she provides technical and managerial assistance to a range of activities within the social and behavior change team portfolio, including support for formative research, technical guidance, and monitoring and evaluation. In this role, Riley has served as the active manager for the two implementation research activities, which we will be discussing today, adding to her over 6 years of experience supporting global health projects. Riley received her master's in science and public health from the Johns Hopkins Bloomberg School of Public Health. Welcome, Riley. And last but not least, we have Pamela Ncube Murakwani. And Pamela is a health and nutrition lead for the BHA-funded Amalima Loko program in Zimbabwe. Pamela comes to us today with over 12 years of progressive experience in developing and spearheading the implementation of health and nutrition interventions. She holds a master's degree in public health and nutrition from the London School of Hygiene and Tropical Medicine in the United Kingdom. Welcome, Pamela. So we are going to, today we will look at the background of the USAID Advancing Nutrition research, hear the process and findings of phase 1 in both Zimbabwe and Malawi, and dive deeper into phase 2 and the prototypes co-designed by care group participants across communities in both countries. So we're going to have about 20 minutes at the end for questions and answers and closing remarks, so that we can spend, about half of our time listening and learning, and then half of our time discussing and really absorbing that information. We are going to begin today with a short poll. Give me just 1 second to bring that up. So you should see a poll appear on your screen. And a question here about how do you engage with care groups? And we have some answer choices. So if you wouldn't mind responding to that now. And while you are responding to that, I'll take this moment to remind you that we will be keeping our microphones and videos off during this call. And if you have any questions that come up during the webinar, please put them in the chat, or you can save them for our Q&A session at the end. However, Karen and I will be watching the chat during the call to make sure that all the questions are captured for our speakers here at the end. I'll give you just another moment to fill out the poll. I'm going to go ahead and end it. I think the results should now appear on your screen. So how do the participants engage with care groups? We see that we have our most as an active implementing partner supporting care groups in communities, which is great. We love that our direct implementers are here with us today. And second is an active implementing partner supporting care groups at a national or subnational level. So those who work on kind of the administration side also present. And then a former care group implementing partner of care groups. or researcher or other. So thank you guys for your participation. I'm going to go ahead and hand this over to Riley.
Great. Thank you so much, Barbara. So without further ado, I expect that we all are really familiar with care groups, but just to give an sort of overarching view of what our research objectives were and our geographic focus, you can see that our objectives were to develop a process to work with organizations and care group members, and then also to work with care group members to design and test transferable solutions to strengthen the quality of care groups for nutrition programming. And you can see our focus was both in Malawi and Zimbabwe. In Zimbabwe, we focused on 3 districts, Chilocho, Binga, and Lupane. And then in Malawi, we focused on 2 traditional areas within Dowa and Salima. So you can see here on our slide the research questions that guided our study. We were able to answer the first question with phase 1 of our study, and then the second question in phase 2. However, the third and fourth questions were not able to be answered. And then throughout the research process, the research team thought of quality in terms of 5 domains that surfaced in a formative exercise. And you can see those 5 domains here on the slide. They are structure, membership, facilitation, focus for behavior change, and community linkages, or linkages to address structural factors and lead to sustainability. And these domains complemented the care group participants' definition of quality and helped us sort of outline focused design questions, which we'll talk about a little bit later in this presentation.
Thank you, Riley. So Amalima Loko, in terms of the program, aims to improve food and nutrition security in 5 districts of Zimbabwe's Matabeleland North region, Binga, Hwange, Lupane, Gai, and Cholocho, through increased food access and sustainable watershed management. And under Amalima Loko, care groups consist on average of groups of up to 10 caregivers of children under 5, led by a volunteer lead mother. The care group meets regularly, typically once to twice a month, for a participatory nutrition education session that is led by the lead mother. And the members also receive household level support visits and counseling from the lead mother.
Thanks, Pamela. Under our current terms, care groups consist of groups of 8 to 10 cluster leaders, which are supervised by care group promoter and led by an elected cluster leader known as care group leader. Care groups typically meet twice per month with variable duration, and each cluster leader supports 8 to 12 households with counseling on prioritized behaviors. These groups irregularly convene for meetings as clusters, and the implementing partner choose to focus on the care group level for this research.
Great. Thank you both, Dr. Kondwani and Pamela, for sharing just how the structure varies a little bit in both Zimbabwe and Malawi. So now we're going to take a look at really the structure of the research, beginning with phase 1. So in Zimbabwe, we used a participatory people-centered methodology known as human-centered design, or HCD. And while there are many types of HCD processes, we used a double diamond approach that contains 2 phases with subphases to broaden and subsequently focus scope. In phase 1, we conducted individual interviews with neighbor mothers, lead mothers, care group promoters in Binga, Lupane, and Chilocho districts, as well as Amalima Loko national and district level staff to understand and document a range of experiences and perspectives. The research team used Atlas TI to thematically analyze the data and then synthesized key findings using HCD tools as a framework. We'll talk about those tools in just a second. But focusing on the HCD tools and an experiential quality matrix, the research team sought care group participant feedback and input on findings in district-level semi-structured focus group discussions in January of this year. And the refined tools were used as a foundation for ideation of solutions, which Pamela will share more about in a minute. And then in phase 2, care groups tested and refined prototypes twice. For each round of testing, the research team observed and conducted focus group discussions, and then data from those observations and focus group discussions were thematically analyzed. And then in Malawi, like other popularized design approaches, living labs was initially developed for and used in the private sector. It's been increasingly applied in the public sector, particularly for environmental and healthcare-related challenges. But the approach is really characterized by an immersive innovation environment, and then 3 distinct phases, which we refer to as exploration for phase 1, co-creation for phase 2, and evaluation for phase 3. So in that phase 1 exploration, we focused on the first research question that I shared just a couple moments ago. And the team synthesized findings of a desk review of implementation partner and participant experiences with care groups in Malawi between the years of 2015 and 2023 into the 2 HCD tools. Similar to the process in Zimbabwe, these tools were shared with participants in a focus group discussion for validation and to seek their input on the synthesis of our findings. And then phase 2 is also quite similar to Zimbabwe and focused on testing and iterating solutions or the prototypes with care groups. And we were able to achieve 4 iterations in Malawi. And again, we'll talk about those in just a moment. So I mentioned that both studies, the research teams used HCD tools to synthesize preliminary findings to validate with and seek input from participants. And these tools aimed to ease interpretation of the findings by care group participants with variable education levels in rural communities in Malawi and Zimbabwe. The journey map at the top of, or at the bottom of the screen outlined 4 stages. The first is starting a care group, and then proceeds with joining, attending, and sustaining the care group. And you can see that those last 3 sort of become their own cycle. And then at the top, you can see an empathy map, which captures what participants hear, see, think, feel, say, and do related to care groups in a particular, and with any particular focus on challenges and opportunities at the bottom, which you can see as pains and gains. So participants also validated findings on their perspectives of what makes a quality care group, and I'll pass to Pamela to share more about what we learned in Zimbabwe.
So in terms of defining a quality care group in Zimbabwe, across the communities, we heard that a quality care group is united with members who are peaceful and open to learning. It's a group that has tangible success, both at the community level and regarded as such, also at the household level. So Lead Mothers built on this, sharing that a quality care group contains members who consistently and actively participate during meetings and who can visibly demonstrate changes based on what they're learning in the care group. Commonly cited challenges to achieving this quality group were a lack of timeliness, with care group participants often running late. Another challenge cited was the repetition of topics, which might not be relevant to the needs of everyone in the group at various times. And a third challenge was the low interaction, particularly in newly formed groups, due to group cohesion not being very strong at the start. And ultimately, there was a real desire for more interactive, participatory activities and facilitation approaches. In terms of participant perspectives on the quality of care groups, I'm just going to cover the next few slides that highlight some of the illustrative quotes from across the quality dimensions mentioned in the desk review of the research. The data supported these dimensions as core to establishing what care group members defined as a quality group. You can see here from the quotes about membership from participants in Lupani and Binga, even among groups that did not report strong friendships or strong social bonds between members, care group participants expressed that a shared sense of belonging was an essential element of care group quality. Other frequently reported elements were unity, harmony, respect, and love within the group, as well as a willingness to learn and advise each other. For example, having participants who are also humble enough to find out information that they may not be sure about. So in other words, a willingness to learn from each other within the group. And in terms of membership, you can see in this second quote here that quality was often described as responsiveness to member needs, as well as interpersonal dynamics, more so than so-called peerness, which was described in the literature. Next slide. We learned that care group members often joined following requests from lead mothers that they know personally, and that group members often appreciated differences between one another as aiding quality. Though, as I mentioned on the last slide, the literature review emphasized the importance of peerness. We also learned that a desire to see and participate in visible changes in their homes and communities was a motivator for the participants. These were often visible changes like the creation of tippy taps, which are a type of hand washing facility that use locally available materials, as well as the creation of pot racks and so forth. Some groups mentioned that community members and leaders contributed to or supported their care group, and a few were specific about how community leaders were engaged, which was largely to settle disputes or conflict in the group, or to provide lead mothers with time to share announcements, for example, during community gatherings or meetings.
Great, thanks so much, Pamela. So in Malawi, we found that care group members shared a lot of the same ideas about what makes a quality group. A quality group is, again, united and harmonious. The group works together to improve households and communities, but there was also a real emphasis on a need or really a desire for technical and soft skill capacity. Challenges were also quite similar between the studies. Participants considered a lack of timeliness as a key barrier to quality, and somewhat distinctly, we also heard about a lack of trust and unclear communication between implementers and care groups in their communities.
Thanks, Laile. Again, like in Zimbabwe, in Malawi, group members reported that a quality group consists of members who are open, willing to learn from one another and work together to achieve changes in their homes and communities. But a core difference is that care group members and community leaders didn't feel the structure of the groups or incentives for participation was very clear. And people wanted more clarity, and you can see that here in the second quote, where the promoter is talking about a desire for rules. In terms of opportunities to achieve the member-defined quality, we held about broad interest to participate in or learn from the groups, which is illustrated really nicely by the quote here from a promoter in Chakadza, that's in Dowa district. We also held from some groups that initial engagements with village leaders during the inception of groups was really positive, and there could be an opportunity to strengthen community ownership and recognition of the groups as a community platforms rather than project platforms. And lastly, and I cannot emphasize this enough, we held time and again that social cohesion and support within the groups was essential. And this is documented in the literature too. You might think of Henne Pellet's description of the support within the groups as a secret source, and we kept hearing feedback from participants that attested to that.
Great, thank you both so much. And we have just one more poll. So Barbara, if I could ask you to launch that for us real quickly and give folks just a few moments to respond.
Yes, let me do that right now.
Great.
Great.
Go ahead, Barbara.
I was like, you should see a poll up here on your screen, which says, which participant defined quality elements are the most interesting to you? And we provided a few choices here. Please go ahead and answer this poll, and we'll continue. Yeah, just a few more seconds. So we have 60% people responding. So if you haven't, please go ahead and choose your answer. And I'll close it in just like 5 seconds. Okay, the responses are now jumping up a lot faster. So I'll give you another few seconds. Great. Okay, I'm going to go ahead and end the poll now.
Great. Thanks, Barbara. So this is really good to see. It's pretty even across the different categories, but we can see that folks are a little bit more interested in social support for action, and then community linkages and recognition of groups. So we're going to talk about each one of these bit by bit today. So I'll go ahead and stop sharing that now, and we'll go ahead and move into phase 2. So now that we know how care group participants think about a quality group, and we have a growing understanding of what they think of as promoting or eroding that quality experience, in phase 2, we focused on co-creating prototypes that would support that vision of quality. And the prototypes that were co-created really do map quite nicely across those different dimensions that folks expressed interest in that poll just a moment ago. So in each activity, phase 2 began with a co-creation or ideation workshop. Pamela and Dr. Kondwani will share a bit more about those in the next couple of slides. But after we had a list of concepts, the research team developed low fidelity prototypes. And that's really something tangible that care group participants could engage with and react to. And these were shared for feedback with care group members, specifically leaders of the care group, so lead mothers and promoters in Zimbabwe, and then care group leaders, cluster leaders in Malawi, during a sensitization session, which is that dark blue box in the middle of the screen. This is also where members could heat map the solutions that they were most interested in trying, and we used that heat map to select the top prototypes to test. In Zimbabwe, testing included 2 rounds of iteration, which I mentioned before, and then again in Malawi, testing included 4 rounds of iteration in communities that expressed the highest interest in the prototypes. So I will pass to Pamela to share a bit about co-creation in Zimbabwe.
Thank you, Riley. So in February 2023, which is earlier this year, USAID Advancing Nutrition and the Amalima Loko team co-convened a 1-day ideation workshop. No care group members were present at this workshop. So the workshop discussions looked at key questions such as how might we engage family members to support care group participation, as well as other questions which are highlighted on the slide. The workshop participants generated and prioritized solutions to care group participant-identified challenges, and in total, 18 potential solutions were ideated. Thank you. Over to Dr. Kondwani.
Thanks, Pamela. And in Malawi, the co-creation workshops took place in June 2023. That's early this year again. And there were 4 workshops that we conducted, 1 in each traditional authority, that is in these 2 districts, Salima and Doa district. And these included Akurenditan's staff, the research team, this is from MUBAS, and care group members themselves, community leaders, and HSAs. And in total, we had 10 solutions which were ideated across the workshops, and the slide is highlighting some of these.
Great, thank you both so much. Okay, so what did we co-create together throughout phase 2? So care group participants in Zimbabwe co-designed 4 solutions, and care group participants and community stakeholders in Malawi co-designed 3. These are listed on the slide with enhanced quality domains. So these domains were conceptualized by combining the domains that were identified as a technical team during the development and implementation of this research. So really those that surfaced during that formative desk review we mentioned in the very beginning, with those that were identified by care group participants in phase 1. And we're excited to share that each of these prototypes will be accessible to those who are interested quite soon. They will serve as a public resource for implementing partners and other stakeholders to generate additional ideas or solutions, and especially for local adaptation. We're going to take a deeper look at each of these, so keep in mind that the snapshots on the following slides are from the English versions of the tools, but we did develop Ndebele and Tonga versions in Zimbabwe and Chichewa version in Malawi.
Thank you, Riley. And so I'll talk about some of these solutions. I'll start with the commitment card. So feedback from the co-design and iteration of the prototype indicated the usefulness of engaging family members to support care group attendance and participation, as well as health and nutrition actions at the household level. Neighbor mothers felt good that they could choose who in the family they would ask for support. Their commitment partners or the people they asked for support took the responsibility seriously. Neighbor mothers and their family members also appreciated the commitment card and approach, noting that it's a useful reminder of the support that they required or that they needed from their family, as well as sharing information with the household. And this actually complemented household visits, which were conducted by lead mothers. And it was a means of accountability as well for attending sessions. And the fact that the commitment card was easy to understand as well as to use. And so from a programmatic perspective, the commitment card is easy to harmonize with program activities. It serves as a reminder of the importance of commitment from key influential family members. And for the Amalima Loko program, this has helped us to look at ways to strongly engage influential family members such as grandmothers and mother-in-laws, as well as husbands, to ensure support for the mother. And the commitment that they make also helps to contribute to this. The commitment card itself is pictorial, it's simple, and it serves as a great reminder to what's being committed to. And our program is currently in the process of adapting the commitment card. And most importantly, the key behaviors that we will focus on are what we call priority behaviors within the program. These are behaviors that will contribute the most to the achievement of recommended health and nutrition practices. Next slide, please. And for the simple job aid for reflection sessions, this provides an adaptable template for facilitating a care group meeting to reflect on the practices or behaviors that they've tried at home. Participants of the co-design process liked the prototype as a means to increase problem solving and efficacy, to act as well as a way to generate social cohesion and support between the different group members. And on the slide, there's a really great quote from a lead mother in Lubani district speaking to this effect. Next slide, please. And so something that I think many implementing partners already realize is that the women participating in care groups want to have fun, just like anyone else does. And this prototype leverages fun activities, which we've called welcome exercises, to foster connection, to help with cohesion, and to help participants feel more comfortable at the start of a group session. While nearly all care group participants expressed enthusiasm or appreciation for the welcome exercises, there was also a really great interest in the probes and facilitation tips included in this prototype. And many felt like the prototype helped them to reflect more deeply on what they had been trying in their homes between care group sessions, especially around the adoption of the different health and nutrition practices. Next slide, please. And so we'll look at the next solution, which is the drama development guide. The Amalima Loko program included dramas as a way of engaging.
Pamela, if you're still speaking, could you please check your mic? I think we might have accidentally muted you.
Okay.
Thank you.
Sorry about that. So drama development guide. So the Amalima Loko program included dramas as an engaging participatory facilitation method. And what we learned through this research is that lead mothers could use more support to guide their groups in creating relevant dramas informed by both their lived experiences and the curriculum of the program. So this prototype was co-designed to be used by lead mothers and incorporates several components we've seen already today, like a structured session guide and energizers or welcome exercises. And you can see appreciation for this approach in the quote here from a lead mother in Lubani district, whose group chose to develop a completely original drama. Next slide, please. And so continuing on the drama development guide, the prototype includes 2 approaches that lead mothers can choose from to develop a drama. The first uses a bank of ideas of what we've called seed stories. And you can see a snapshot of one of the dietary diversity seed stories on the slide in blue. The second approach guides a lead mother and her care group to develop a completely original drama, including a coherent plot based on a key message and member-defined characters so that everyone has a chance to be involved, they have a chance to participate, and lots of time for discussion to develop the narration and ultimately reflect on their own lived experiences of trying different recommended behaviors. Thank you.
Thanks, Pamela. So the final prototype co-developed in Zimbabwe is called the Look and Learn for Care Group Leaders Guide. It shares tips for facilitating a look and learn session. And during that session, a hosting care group leader and promoter invite visiting care group leaders to observe a care group session. And then after that session, the care group leaders and promoters debrief with one another to share recommendations and reflections on the session. The guide was designed to be used by a care group leader and/or a promoter. And the quotes here on the slide demonstrate the incredible enthusiasm participants from all levels of the cascade shared in Zimbabwe, that the sessions were empowering, that they lent validity or credibility to what lead mothers were sharing during sessions, and similar sentiments were expressed in Malawi too, but I'll get to that in just a moment. So during early discussions with the Amalima Loko staff, and even during that ideation workshop that took place in February, facilitation guidance kept emerging as a need. And while so many lead mothers appreciated the facilitation tips that were included in this prototype, iteration with care groups demonstrated that they, the contributing lead mothers, were really the best actors to provide facilitation tips to one another. So the guide shares some foundational tips that are really helpful for new leaders, which of course came out of that iteration process. And you can see one of those tips shown on the slide here. But really the real value of the prototype is its ability to foster peer-to-peer sharing or mentoring. So the same value held true in Malawi, where the prototype that was originally co-developed in Zimbabwe was tested and adapted by local communities in Malawi. They added more foundational tips, and unique steps for coordinating the sessions that was responsive to the nationally adopted variation of the care group model. And one benefit of this approach is that it leverages the cascade structure to amplify mentoring and peer-to-peer sharing as a means of capacity building. The second, and I think this is really nicely demonstrated by this quote, that the approach creates a needed opportunity for collaborative problem solving around sticky issues like tardiness and facilitation.
Thanks, Laile. So in Malawi, on a simple job aid for facilitating skills session with the communities we were co-designing with in Malawi, we learned that more capacitation on facilitation skills was needed, and group leaders really want that support. This led to a prototype that outlined adult learning principles and then used practice-based exercises to illustrate core soft skills and technical concepts prompted by the program. You can see a quote here from isolation with a group in Mwanza, that's in Salima district, where the care group leader appreciates the adult learning topics and practice exercise on teamwork. Next slide, please. This is an example of the time management soft skill. Like the technical skills, there is a definition of the key term and locally adapted example of that skill, and a fun exercise for the group to practice the skill. For technical skills, this practice is acting out a counseling scenario. Course on this slide demonstrates the overwhelming appreciation for welcome exercises and opportunities to have fun. Next slide, please. On the community leaders' aid for supporting care groups, as I mentioned earlier, we found that even in communities who were aware of care groups, many community leaders did not know what care groups do or how to support them. And leaders within decentralized government structures called village development committees were enthusiastic about their newly realized role to sensitize their communities about care groups and support the work care groups do, especially for community development. You can see two great quotes here from this slide. Leaders in Chakaza and Kulunda to this effect. The prototypes they could design include guidance for planning and facilitating a VDC meeting, a monitoring tool, and suggestions for disseminating progress, successes, and so forth. Next slide, please. And the real focus of iteration was the facilitation of a VDC forum. You can see an excerpt here from the section on feedback from care group leaders. VDC members thought it was important to build a meeting time to hear directly from care group leaders or promoters to get updates and hear where support is needed from their perspectives. You can see a quote here from a leader in Chakaza appreciating the approach for forming a bond between the VDC and care groups. Next slide, please. And here, the prototype also includes a simple monitoring tool that community leaders can use to inform VDC meetings and their support for groups. Though engagement in monitoring and accountability was highlighted in phase 1 and the co-creation workshop as a key interest and need among leaders, this was significantly lesser focused during iteration, where the direct engagement with care groups through the forum was a clear priority.
Okay, thank you very much, Riley, Pamela, and Kondwani for your presentations. Very interesting, and I love how so many different ideas have come out of your work together with participants, with staff, and working together. So now we're going to move into some Q&A time. So if you have a question, you can feel free to put it in the chat, or if you would like to raise your hand and use the mic, we are happy to open it up for you. Are there any questions?
I have a quick question. So Riley, you had mentioned that these resources will become available soon. And I was wondering if your team had an estimation on like what soon means. I know that's not often always in your hands. But then also if there's any plans to have training sessions or discussion sessions around the individual tools so that people could, really understand their use. Thank you.
Yeah, thanks for that great question, Barbara. So you're right. The final presentation of those tools, getting them really out and ready, that is out of my hands and in the very capable hands of our knowledge management team. But we do expect that they'll be available likely by the end of the year. And we don't have any plans for capacity building around using the tools, but they were co-designed with community members so that they are really pickup ready. Each tool contains a small section with some background on how the tool was developed and some very practical guidance on how to use the tool. So theoretically, anyone who is able to read can pick up the tool. There are some tools like the commitment card that Pamela so nicely shared with us that are really intended to be used by both audiences that are literate and those that do not have literacy.
Okay, there's also two questions in the chat from Lisa, and it is directed to Dr. Kondwani. Could you please share more about plans of community leaders for continued engagement and support of care groups, if you've heard of any?
Yeah, thanks very much for this good question. I can say that the community leaders, what they were suggesting and planning to do to ensure that there is continuous engagement in the care group activities was to use the existing structures, which do have their representatives. And these are the village development committees that are situated in each village in Malawi. So what they were saying is each particular village development committee, whenever they are having their monthly meetings, they should always have representatives from the care groups to update them on the progress of how care groups are performing in their village, and if they need any support from the community leaders, as well as how can the community leaders also come in and help whenever there's a need to do so. So with the use of the existing structures like the village development committees, that may help to ensure sustainability of such kind of arrangements. Thank you, and over.
And follow-up, another question. You talked about community leaders in Malawi not knowing the role of care groups. What plans do you have on this? Can you tell us a little bit more about that?
Yeah, this is really quite interesting because in most cases, before we carried out this research, we thought that all the leaders at each level are aware of care group activities. But through this research, that's when we noted that others were not really having enough information about the care groups. So the one way of ensuring that this happens is what I've said in the previous question, to say there should be continuous engagement of such leaders through the existing structures like the village development committees, but also there's a need to reach out to the policy makers, because we do have a policy on care groups and some guidelines have already been developed, but maybe those may require some revision so that we provide more opportunity for frequent engagement with community leaders as we implement care group activities in respective communities. Thank you.
Thank you, Kondwani. A question here from us. Another question from Florence is, to what extent did the approach incentivize the care group participants? How do the care groups interface with the government or MOH and the existing local health systems? I think that anyone who feels like they want to take that question could pick it up.
Maybe I can start. For Malawi, when we were trying these prototypes, I should say that we did not really.
Kondwani, would you mind checking your mic? I think we accidentally muted you. And for audience members, if you could please keep yourself muted. I think in our quest to then mute open mics, sometimes we accidentally mute our speakers. Thank you.
All right, thank you. Can I go ahead?
Yes, thank you.
All right, thanks. So I was saying that for Malawi, all the prototypes that we tried and even developed with the communities or the participants happened right away in their respective communities. And there wasn't any kind of incentivizing for them to participate. And this was done deliberately so that whatever we tried in terms of the prototypes should fit in the local context, and it should provide that opportunity for sustainability in case there's a need for scaling up and also projects to uptake whatever we tried. So there wasn't any kind of incentivization, because sometimes that brings problems when projects have phased out. Thanks, and over.
Okay, and then there's a question here for Pamela. Thank you for the beautiful presentation. Could you share any ideas about the best time to listen to groups like you did? Is it good anytime in the program or better at the start of a program?
Thank you. Thanks for the great question. So best time in most cases is usually at the start of the program to enable any refinements of the approaches that one would be running with in terms of implementation. For example, with the Amalima Loko project, we started implementation in 2021, and we had a period that was called Refine and Implement. And this enabled us to learn from the communities through different processes, including a process that we called community visioning, and to also collect information. And this was really essentially at the start of the program. But at the same time, we do recognize that there is need for using research approaches that may take time, that delve deeper and give one much richer information. For example, the human-centered design approach. And this could not be completed within the start of the program. It was a bit of a lengthy process, but the gains and the findings from that have been very important for us. And they help in terms of adaptive management as we look at the way that we will be running with care groups as we move forward. And it's a critical part of programming. And we will be able to make the necessary tweaks. We've already started working on adopting some of those prototypes and changing some of the approaches in terms of what we've been doing to incorporate the findings and build some of these solutions into the care groups. So it can be better at the start, but I think if you're using a methodology that helps you to learn more from communities, then this can be done even up to midway within the program, which is what we have done through HCD together with USAID Advancing Nutrition. Thank you. Over.
Great. Okay, our following question is from Shanika Thurman. Congratulations, Riley, Pamela, and Dr. Kondwani. The prototype solutions are super interesting and will be helpful to so many care group implementers. I'm curious about next steps. Are there any plans to continue to track the implementation of these solutions, specifically to explore the role that they have in helping to change the behaviors that the programs are promoting? So, and that was that's a question I had to. So yeah, go ahead.
Yeah, thank you. Thanks for the question, Shanika. So for Amalima Loko, I think one of the things that we have really prioritized, especially for this period after the findings came out, and we have these different solutions, the 4 key solutions that we'll be running with. We are working on how we make the necessary adaptations in terms of our care group approach to build these solutions in. For example, for the commitment cards, we're in the process of working on the design of the commitment card, as well as translating the card into various languages, including a language called Nambia, spoken by the neighbor mothers. And once that's done, we'll make sure that all our neighbor mothers receive a commitment card. And for the drama development guide, we have incorporated some of the key information in some of our care group materials. And from what the USAID Advancing Nutrition team have developed, we have also started to put together a brief guide that will be translated into the local language for the care group promoters and the lead mothers to use. Similarly, for the Look and Learn guide and the Simple Job Aid for reflection sessions, we will be working on a brief guide for the lead mothers to use. And in terms of timelines, we expect all this to be completed by early next year, so that we have sufficient time to build the capacity of the lead mothers in terms of using the different guides and making sure that we attain our health and nutrition objectives through improved quality of care groups.
Maybe just to quickly add on to what Pamela just said so nicely, under USAID Advancing Nutrition, because the project has officially closed out, we do not have any formal plans to track the implementation of the solutions. But you might recall that in Malawi, we had planned an evaluation portion of the study, but unfortunately did not have enough time to complete that. So with the idea that all of these tools will soon be available for use and ideally local adaptation, it would be wonderful to see other implementing partners take up these solutions or develop their own and share their findings on how the solutions support quality in their own groups. So just an exciting plug to say that this research can very much be picked up and carried on by others working in this field. Thanks.
So that we have some work to do, I guess, don't we? So we're just going to pause the questions for a couple of moments so that we can wrap up our conclusions. We're about at the end of our official time. So we're going to let the conclusions kind of be shared out, and then we'll come back to the other questions. And if you can stay on, that would be great. If you need to go, we understand. So Riley, if you would like to go ahead and take that on.
Yeah, thanks so much. Okay, so we have 2 categories of learnings to share based on what we talked about today. First, in the red, you'll see care group focused learnings. And then in the blue, we have some learnings that are related to linkages with communities and families or households. So first and foremost, as Pamela said, care groups should have fun. Care group members value group unity and cohesion as key elements of a quality care group. And we've known this for some time. Participants in Zimbabwe and Malawi felt that fun activities and the prototypes they tested helped to build a sense of unity and friendship within their groups. Next, we learned to not neglect the soft skills. We know that quality counseling requires more than technical knowledge. How counselors interact with their clients or households is critical, and those skills are broadly applicable to care group facilitators. And we can see this come into practice through those look and learns and through that simple job aid for facilitation skills sessions. And then finally, care groups can learn from and be accountability mechanisms for each other. Throughout iteration, care group leaders and members were enthusiastic about learning from one another and about sharing their skills and insights with one another. We also heard leaders talk about how learning and mentoring opportunities like those of the Look and Learn could encourage accountability. So in terms of those external linkages, we know that community ownership is a key enabling factor for quality implementation. It's important that care groups, or rather that communities, see care groups as community platforms. And we heard this from care group members who defined a quality group as one that leads to visible improvements in their community, just as much as we heard this from community leaders who hold influence and authority to support the care groups. And then last but not least, in some communities, family approval or consent was also a key enabling factor. And I'm sure we can all recall a time when the support of a family member or close friend helped us to adopt a behavior. To this effect, engaging family members can have the benefit of fostering an enabling environment in a care group member home and social support for trying recommended behaviors outside of the care group. And we've summarized all of these key learnings, and there are some additional learnings summarized in 3 briefs, which will be available on the USAID Advancing Nutrition website in the coming weeks, probably about the same time as the prototypes are available. So hopefully by the end of this year.
Okay, great. Thank you, Riley. I think we're going to just wrap up officially. I have one last poll to share. If I can throw it out there. The care group interest group is, we are here to provide support to direct implementers of care groups, managers overseeing the process, and researchers. And we're just a group of people who really love care groups and like to talk about them. We really like to learn about them. And so if you would have any specific topics, this is set up as a poll and it's supposed to be an open. Can people write in their questions, their answers here? I'm not sure if you can, but if we'd love to hear more topics that you or your team would like to learn about through participation in this group. So I think if you have the option to write in an answer, please do so. If you have some topics you would like to learn about, we would love to take those ideas on and see how we can address them in future webinars. If you're not part of our listserv, you can join by sending an email to subscribecaregroups@fh.org, and we'll put that in the chat in just a second. And just write subscribe in the subject line, and we will add you to our list, and you'll be able to get emails from the group, as well as send your own emails or questions to others. I'll put that out there. Barbara, I don't know if you had anything else you wanted to add at this point.
Sure. Thanks, Karen. And, to echo what Karen was saying, like, it's an all volunteer group. We love care groups. We want to use this group to share ideas, to really just help each other improve in the implementation of care groups, and, the measuring of care groups and all that stuff, which is, why these kind of presentations by Riley and her team are really just so crucial for our joint knowledge. We are looking for additional presenters. We have, more formal presentations like this. We could, even have people who are interested in leading or, co-leading a discussion. So a bit more like interactive with breakout rooms and things like that, or a bit more informal, perhaps. So if you think that you would like to do that, I'll go ahead and put my email, and Karen can put her email in the chat. And we would just love to hear from you. Even if you just have kind of a rough idea, we're happy to work with you to refine that and build it out, and look for other people. If you don't want to do a presentation all on your own, we can help you look for other presenters. But this group survives on the contributions of its members, and so we hope that this is the first time you're joining us today. This isn't the last time you'll be joining us, and we hope that participants are also leaders in this group. So thank you in advance for your interest in continuing to be involved and also take a leadership role in this. And I see we've had 12 people answer the poll. So I'll give you another 5 seconds. If you have an answer being crafted, please go ahead and just submit it. If you just even want to put your email and say you'll email us later, that's great too. But then I'm going to end the poll, and I think I can share it. Still a little bit new to polls on Zoom. Okay, I'm going to do that now. And I can share the results. So if you click on, at least on my screen, it has view details. So you can go ahead and see what others in this meeting are interested in. If you had another idea that occurred to you, please feel free to just throw it in the chat. But I think at this point now, we are going to return to our question and answer session. I know that we had about 4 unanswered questions that we could begin with, and then we could, of course, add on to that as we go forward. Karen or Riley, back to you. I guess Karen, back to you.
Sure. So we'll continue on. If you need to drop off at any time, that's fine. And we'll send out links and presentations afterwards, so you won't miss too much. So I'll just continue on from where we were. What additional challenges have you faced in sustaining the care groups? Could you talk of some linkages with other programs, such as VSLAs, IGAs?
I'm happy to get us started with this one, and then maybe Pamela can take it over to share her wonderful insights. But in phase 1, particularly in Zimbabwe, where we were interacting with groups that had formed under the previous project called Amalima, we found that group members who were really identified specific benefits with their participation. So that's that visible changes in their homes and communities, and that really strong social support. Those were key to those groups being sustained between Amalima through Amalima Loko. And in some cases, some of the groups, were really still looking at care group content, like exclusive breastfeeding and complementary practices, but others had sort of evolved in their purpose. So some were, either transformed or including VS&L components. So that's the village savings and loan activities, or even income generating activities like WEMA suggested. But then others were, burial groups or other such things. So just again, illustrating that, sustainability from a participant perspective, at least, was that social support and those social linkages staying continuous. Pamela, anything to add?
Thank you, Riley. Thanks a lot. So maybe I'll just start off by highlighting the fact that the area or the region where we're implementing the program, the Amalima Local program, is dry, arid, low rainfall. And so a lot of the usual challenges are around issues of access to resources for mothers, especially when it comes to health and nutrition, especially with the issue of seasonality, which is worsened by the climatic situation. And so the VSL approach, village savings and lending, or the ISL, internal savings and lending approach, is something that we have made sure that is integrated within the care groups that we're promoting within the program. So I'm speaking more broadly to these care groups that are being supported by the program. We have over 36,000 neighbor mothers that are actually in care groups. And so building in the VS&L approach, the VSLA approach, has helped in terms of making sure that mothers have access to resources in order for them to be able to make some of the recommended health and nutrition or to adopt the recommended health and nutrition practices. And due to the issue of seasonality, you can actually procure some of the foods that may be required for improved nutrition or resources to access the health facility and so forth. The other piece in terms of the challenges that Riley has already spoken to is around the social support, especially when it comes to male involvement at the household level. We do have a component of the program that is looking at engaging men effectively at community level for improved health and nutrition. And so this is helping to complement some of the care group activities. And then the piece around the motivation. Obviously, if you're working with a large group of volunteers and building their capacity, and they've got deliverables that they are required to focus on at community level, the intrinsic motivation is critical. And to address this particular challenge, what we have done is we have raised a lot of awareness on the care group approach amongst community leaders. And once these lead mothers have that recognition in terms of their role from the community leadership, and that linkage between the lead mother and the community leaders is strong, this has contributed to sustainability in terms of the care group approach. I could talk about this all day. It's one area that I'm really passionate about, but I think I'll stop there, and I hope that I've spoken to the question. Thank you.
Great, thank you so much. Another question is, are there already, a question about the dramas. Are those dramas already prepared in the module for volunteers, or does each volunteer develop their own drama that suits their needs in their area? Can you explain a little bit about how that works?
Sure. So the drama development guide was used exclusively or co-developed exclusively in Zimbabwe, and it contained two approaches. So it both includes short sort of prompts, short stories really, that a care group can build a drama off of, like the example that we showed before about dietary diversity. So really a kind of challenge statement, setting up a scenario, and then members can build their drama from there. Or there's a second option where volunteers, care group members can develop a completely original drama. So it explains the fundamental pieces of a drama, like what is a plot, what is it to have a central theme, what are characters, and how do you develop a narrative? And it's a lengthier process. So just really emphasizing more time for reflection in that second option. I hope that helps to clarify, but Pamela, please feel free to jump in if there's anything I missed.
Yeah, maybe just to highlight the fact that before we had this, the finding from the research in terms of the solution that the research team came up with, a lot of the dramas were actually coming from the lead mothers. They were coming up with the ideas themselves, and to some extent kind of imposing a drama idea on the care group members. And in terms of the drama development guide, it's really encouraging the ideas to come from the mothers themselves, the neighbor mothers that are in the care group. And through this way, the neighbor mothers are actually able to dramatize some of their lived experiences, and it brings out some of the real context-specific issues that they're facing when it comes to health and nutrition challenges at the household level, at the community level. And this is what the mothers then dramatize, and it helps the lead mother to also understand what some of the key issues are that the mothers are facing, and to provide the necessary support that they need in order to be able to address the key issues. For example, the issue of time poverty for women, issues around health and nutrition issues that are deeply rooted in culture, or food taboos or religious beliefs. So a lot of those things come out when the communities or the neighbor mothers themselves dramatize these issues. So it's excellent that we had this drama development guide that is really shifting the focus to the neighbor mothers and getting them to dramatize their lived lived experiences. Over.
Great, thank you, Pamela. There's one follow-up question for Dr. Kondwani about some of the not knowing the role of care groups in the community. And so we're just wondering, did you find out in this study any of the reasons of the community leaders not knowing about care group roles in the community? Was there any further light shed on that?
Yeah, thanks very much for the question. We tried to get some details in relation to this, and one of the issues that came up was that normally when the project is starting, like maybe an implementing partner wants to introduce a care group project in a particular area, they do carry out some sensitization activities whereby they involve the local chiefs. So in this kind of sensitization, in most cases, what we got was that the sensitization doesn't really involve all the chiefs, but they may just maybe bring together some local chiefs in an area, maybe those that may be of slightly higher level. And once those ones have been sensitized, then they are responsible to share the same information to the junior chiefs that they are under them. So they were saying that that's where maybe sometimes there's a gap that that information does not come clearly to them. In the end, they don't have the details about the care groups. And also sometimes they have some other structures that are created to work with the care groups. And in this case, the chiefs that sometimes are involved are those who participated in the sensitization, but also sometimes whenever there are problems with the implementation of care groups, that's when maybe they would want to seek help maybe from the local leaders. That's the point when maybe some other local leaders get involved in the activities. But if the local leaders are not approached in case there are some challenges, then they are not really fully involved in the implementation of care groups. So that's some of the information that we gathered during the research process. Thanks, and over.
Great, thank you very much. I think this is our final question that I see here. And that is, are the care groups learning from each other through some of the cross-learning platforms and improving how they perform? So can you share a little bit about how that tool has been used, or how and what some of the results have been of that?
Yeah, I'm happy to get started, and then both Pamela and Dr. Kondwani could speak to this also. But so for the look and learn specifically, during iteration, which is different than necessarily measuring the impact of the prototype, but while we were co-designing it, co-developing it, care groups were already sharing that they were learning from one another, that they had participated in a session and they really liked how the lead mother was facilitating, so they were going to do that in their group too. And we weren't able to follow that group to see if they had, but just were able to document that very explicit interest. And that was nearly ubiquitous across the different groups, again, who participated in co-designing and adapting the prototype in both Zimbabwe and Malawi. We also heard that from groups, whether they were testing the look and learn or one of the other prototypes that included welcome exercises, that they liked many of those and were already starting to use those in their groups. There was a quote from earlier in the presentation about a welcome exercise called Draw Your Neighbor, where one lead mother had shared that she learned about it in sensitization. We hadn't talked to her in a while, but she really liked it, so she was putting it in her group already. She didn't need us. And so that was really great to see that folks were already really excited about the solutions, were already really excited about learning from one another and taking that forward. So Dr. Kondwani, Pamela, please add if you'd like.
Thank you, Riley. So at lead mother level, there was some learning in terms of lead mothers learning from each other, but it was limited. It was mostly limited to a time when they would come together for capacity building sessions, which were not very frequent. They've not been very frequent on the program, once every few months. But look and learn guide in terms of what is promoting now is for the lead mothers to learn from each other, even when a lead mother is running a care group session. So this means another lead mother from a different community can actually come and sit in and learn from how this other lead mother runs her session, and learn from the ideas that are shared and the ideas that are exchanged within that session. And she's able to take some of these rich ideas back to her group. And one of the things that this helps to contribute to is for them to lead mothers to recognize that they are part of something bigger in terms of a bigger community initiative towards addressing health and nutrition issues. And it contributes to the motivation of the lead mothers in terms of the intrinsic motivation. At the same time, it also helps to exchange, helps them in terms of exchange of ideas, especially when it comes to ideas for enriching the child's food, for example, using different locally available ingredients. And this has contributed to some of the nutrition outcomes that we want to see on the project. So it's good that we have a guide in place now in terms of how, as a program, we'll be able to implement this particular prototype or solution. Over.
Yeah, I think just to add on what Pamela and Riley has said, before our research, or even during the research process, we were trying to check with the participants whether they were able to learn from one another before we tried our prototypes. And what they indicated was that there were a few opportunities that could enable them to learn from other care groups, more especially whenever maybe there's a special function happening in a particular care group, like maybe cooking demonstration or something else, which was not a frequent activity. It's something that happens here and there, and that really did not promote the way where care groups can learn from one another. But as my colleagues have said, the look and learn approach really was something that they liked, because the cluster leaders or the promoters were able to learn how someone is facilitating, and then they could learn one or two skills. And in the process, they could try to apply the same when they are facilitating in their respective care groups. And it's something that can be implemented and within care groups that are living maybe within a particular region rather than those that are far away from each other. So it's something that can encourage care groups learning from one another. Thanks, and over.
I love that. That's really exciting. And that, so finally, this is our very last question that I see going through the chat one last time from Sandra. What approaches have you used to phase out the care groups? And is there a recommended graduation model or approach when a program or project closes?
I'm happy to respond. So in terms of the Zimbabwe care group approach, it's largely led by the Ministry of Health from national level, provincial level, district level, and sub-district level. And in terms of the volunteers that are rolling out the care group activities, they're recognized as volunteers within the Ministry of Health structure. So they're not necessarily volunteers that have been set up by the program per se. And in this way, this contributes to the sustainability piece. Apart from that, we have multi-sectoral coordination structures or platforms at different levels, and these are government-run and government-led structures, right down to the community level. And the role of these structures is actually to monitor care group activities within the community level and make sure that the care groups are sustainable beyond the life of the project. So we have not created a parallel structure as a program in terms of the the different volunteers that we're working with. We're working within the structures that are recognized by government. It helps that the government of Zimbabwe has also endorsed the care group approach. So there's a lot of confidence that sustainability will be in place in terms of these care groups will keep going forward. It also helps that the linkages are strong between the care group lead mothers as well as the village leadership, the community leadership. This also makes sure that these lead mothers are held accountable in terms of their roles by the community as well as by the village leaders. It would not be sufficient for me to talk about the sustainability piece without making reference to a process called community visioning, which we rode on as a program when we started the care group process. So Amalima Loko engaged communities through this process, and it's a bottom-up community engagement approach that helps communities to identify context-specific priorities and solutions for rural communities. And it's a deep, rich engagement. And the engagement started with community leadership, as well as other stakeholders at community level, as well as mothers within the community and other community groups. And this contributed to the communities actually owning the approaches, owning the care group approach, and they're not seen as Amalima local care groups, but rather as groups led by the lead mothers, supported by the different stakeholders and valued and recognized by local leadership, such as the village headmen, the religious leaders, and other members of the community. So pretty confident that the sustainability piece is actually in place and that these care groups will continue, especially now that we have some of these prototypes that we'll be running with, which will help us to further improve the quality of the care groups. Over.
Yeah, thanks so much, Pamela. If I might just add a little bit to that. So you did such a good job of talking about how essential it is for the care groups to have that strong relationship with community leaders as key to sustainability and for there to be this strong ownership. And I think one of the things that we learned in phase one that was not necessarily a surprise, but really changed the way we were thinking about sustainability is that the care group participants, they think about sustainability a bit different than we might as implementers, right? They're thinking about sustaining their groups, keeping those very specific social bonds intact. So whenever implementers are thinking about approaches for sustainability, like a graduation model or something like that, really considering participant perspectives, not to shamelessly plug, but that deep engagement with participants to understand how they're thinking about sustainability, I think can be a really important step into thinking about which process is the best suited for different communities. So, thanks.
Great, thank you so much. I think that here, unless there's any further last minute questions, I think we can wrap up as of now. Thank you so much, Riley, Pamela, and Kondwani for your time today. Thank you for sharing all your learnings and just the things that you've walked through this research. Yeah, we are looking forward to hearing more as things become available for people to access. So thank you so much for today.
Thank you, everyone.
Thank you, everyone. Bye.
Yeah, thanks. Bye.
Thank you. Bye.
Thank you very much. Bye-bye.